Michigan. Dr. George went to residency at Hofstra Northwell, the Smith Institute, where he did an endourology fellowship. He then went to the urological oncology branch, NIH, where he finished his SUO fellowship, and then subsequently went to University of Michigan, where he's now an associate professor. Additionally, he's director of the prostate cancer programs of the Michigan Urologic Surgery Improvement Collaborative. So he'll be talking to us today about focal therapy. So please extend a warm hand to Dr. George. And as he comes up, we also want to thank EDAP TMS for the excellent dinner yesterday.
Great. Thank you, Matt, for the kind introduction, and thank you for inviting me to speak today. And today I'll really be going over the broad concepts of focal therapy. Now, I feel like I could talk about this for a long, long time, but I'm going to try and distill it down to some critical information and then also some cool new things that we're doing in this space. One second. There we go. Okay, so the things that we're going to be reviewing today, we'll start with the indications for focal ablation of prostate cancer. I think the second point is the most important point. The actual technical aspects of doing the procedure are not that difficult, but I think that really the most of it comes into the surgical decision-making in terms of who do we treat for focal ablation. Understand a little bit about the complications of focal therapy and what the time points are, and maybe dispel some myths that still may be lying around. And then briefly go through some focal therapy outcomes. And then after that, I'll be talking about a clinical trial that we have recently completed, the data of which is not available, but the technology is quite unique. So I thought I'd highlight that. So before we start that, I wanted to give a brief note on family. I got a great sense for the team here and the residents here. And I know that when you go through the same experience together, this shared experience, you go through these trials together, you become closer and you become a family. And I'll say that's also very true for my experience at the NIH. That's actually how I originally met Dr. Watson. He was quite precocious in that he was wearing, masks even before the pandemic occurred. This is him as a lab rat. And then, he was always a fanboy of mine. And he even made me his desktop background. And actually, as you can see here, we're both hairier and maybe like a little less trim as we used to be. Okay, so we'll get into the talk now. So the first thing I want to talk about is what is the current indications for any ablative treatment, maybe not specifically for focal therapy. If we look at the most recent NCCN guidelines, it really boils down to either cryo or HIFU in the salvage setting. So these are for men who have experienced a radiation failure. Now, this area, I think, is the best potential area to be able to do focal ablation because the untreated area is already treated. The areas of the prostate that don't have recurrence have been adequately treated with radiation, for example. In this space, many patients have very limited treatment options, and those treatment options have a tremendous amount of morbidity. And so ablation is a really appealing alternative because it's very low morbidity. And for a lot of programs that start out doing ablation, this seems to be the patient population in which they can start their treatments because I think that you have good rationale to be able to support your ablation. And now I think that with the use of novel screening tools such as PSMA PET, we're going to screen these patients who fail biochemically, but really have localized disease rather than distant disease, where we can identify those patients up front, eliminate those out of the pool, and then focus on those who are truly clinically localized rather than treating them and eventually identifying that they develop bulky metastatic disease. So what do the rest of the guidelines say? EAU, they basically maintain their statement from the year prior, that only offer a clinical trial, only offer it within a clinical trial or a well-designed prospective cohort. And then NCCN, it was from November of 2021, noted that it's not recommended as routine primary therapy due to lack of long-term comparative data. But I will say that when we start to look at series that have been published in the literature, and there's way more cases that have been done than have actually been published, but the real world data is actually showing promise. But focal therapy is really the evolution of anything that we've done in medicine. This is not unique, even though we conceptually think of treating an organ-sparing approach for prostate cancer to be unique. That's really not the case. If we look, and I don't like to use this as an example because I think that the parallels in broad strokes make sense, but I think when we drill down to it, they are different disease entities. But if we look at breast cancer, when we look at the Halsted radical mastectomy, We had removal of the breast tissue, the serratus anterior, pectoralis major, pectoralis minor, a tremendously disfiguring operation. And even after there was the modified Halsted radical mastectomy, we have preservation of muscle, still a disfiguring procedure. But where are we now today? We're down to lumpectomy and radiation, nipple-sparing mastectomy, and we get good oncological outcomes at the same time delivering a less morbidity. Now, this approach is, let's look in urology, there are multiple examples of organ-sparing therapy. We have partial nephrectomy, which is not too long ago became the standard of care, transurethral resection of bladder tumors or local management of non-muscle invasive bladder cancer. We treat high-grade T1 consistently with an organ-sparing approach. And when they recur, we still accept that, yes, this disease can recur, and we have second-line agents, third-line agents, second induction course of BCG. We accept that we can perform an organ-sparing approach, even in a cancer that is significantly more lethal than prostate cancer. And then, of course, partial cystectomy, partial penectomy, thyroidectomies, all of these things are just examples of the organ-sparing approach in medicine. So this is not a unique concept. We're just starting to apply this, hopefully in an educated and scientific way, to prostate cancer. So when we talk about patient selection for focal therapy, we're really what is the perfect patient? The perfect patient is somebody who has unifocal disease. We understand that that's a minority of patients. We want to make sure that the disease that we're treating deserves to be treated. So we want that to be clinically significant disease. And there are varying definitions of that. I put this up here, that either by cancer core length or by Gleason score or volume. You want it to be isolated from vital structures, such as the membranous urethral sphincter, the neurovascular bundle, if it can be avoided. Ideally, you want it to be MR visible, so you know exactly how much to treat in the margin that you want to apply. And then you want to be able to make sure that you triage out those patients who have higher risk disease that really likely need to be paired with a more aggressive treatment. So seminal vesicle invasion, extracapsular extension, and the like. Now, what there is still a question on is what we don't really understand this yet is what about the role of genomic biomarkers? We have a number of new risk stratification tools, but unfortunately, these have not really been validated in a focal therapy space. And I think that work is ongoing. And also the ability to leave alone contralateral Gleason grade group 1, that is, I think, 3 to 5 years ago was a little bit controversial. I think that's pretty much accepted here. And to me, conceptually, that also makes sense. We accept by de facto, if you accept active surveillance as a strategy, you are accepting the index lesion theory of prostate cancer. We understand that we only know what we know within the prostate when we're following men on active surveillance. However, we also understand that there is likely occult disease that we don't understand. And even in the era pre all the disease risk stratification tools we had, men still did great. And now we start to move that into a slightly higher risk category and also into the focal ablation space. So I'm going to talk about some relative contraindications, and this also depends on the technology that you're using, whether it be HIFU, whether it be cryo, which system that you're using. But there are gland size limitations because for HIFU, for example, the beam can only reach so far anteriorly. So if your focal point cannot reach there, you're not going to get good energy deposition, and that's generally related to the AP diameter of the prostate gland. Large calcifications, if you can't see through the calcifications, if you can't see on the other side, then there's no way that energy is going to go through the other side, and it can be reflected and potentially come back to the rectum if it's close to the rectum. Inflammatory bowel disease, you don't want to administer a transrectal therapy in those patients who have inflammatory bowel disease. It'll increase the risk of fistula, of course. Multiple prior doses of radiation. We certainly use ablation in a primary salvage setting, but if they've received either secondary HDR brachia salvage, then in those patients, the rectum can be really paper thin and not really well suited to at least HIFU. Potentially anterior tumors can be treated with cryo. And then finally, brachytherapy seeds for the same reasons of calcification. So with HIFU, I know that it's considered a relative contraindication. I avoid HIFU in all patients with brachytherapy, again, because of inconsistent energy deposition and unpredictable energy dispersion. Now, the cornerstone of being able to identify men for focal therapy is your MRI, and not all MRI is created equal. Some here at the top, you can see that's our T2 weighted imaging, and then also our diffusion weighted imaging on the right-hand side of your screen. And that's with an endorectal coil. You can see that in the rectum. And if you look at the transition zone, you can see how crystal clear there's organized chaoses of these BPH nodules. This is oftentimes the most challenging area to interpret. And so having the ability to be able to see those areas clearly really is important to be able to accurately stage these men or screen these men into focal therapy. An example of a paw scan, this is a patient that I've actually seen previously. You can see here, you can't really glean any information from the transition zone. Now, there are challenges even in patient selection. Is it just a fusion biopsy? What happens if the MRI is negative? Are those men still eligible for focal therapy? So theoretically, yes, it may not be the truest focal therapy, or rather a regional or hemiablation. But other methods have been the use of template mapping biopsy or essentially a saturation biopsy. I do think that's probably the best way to stage a patient, but it's not really practical in all cases. And I think that once you know your own data in terms of your outcomes for prostate MRI and fusion biopsy, in terms of the negative predictive value, your upgrading by standard biopsy, you get a good sense of the quality of your MRI, and you can trust that rather than having to perform a saturation biopsy. A lot of people do accept that a negative MRI and a 12-core biopsy is sufficient. And though I technically think that is true in sites that have excellent MRI, again, you are resigned to a hemiablation or a regional ablation. And then there's always the concern that if you miss cancer on the MRI that you identify in 12-core biopsy, did you miss other cancers on the other side? So that I still think is pushing the mark a little bit. So the challenges with patient selection are these patients are heterogeneous. Prostate cancer is multifocal. There's varying definitions into what is clinically significant versus not. When I first started, I was getting a lot of 80-year-olds being referred to me with 1 core or 5% of Gleason 6, and those are not the patients that are really going to benefit from any treatment. We select these patients with a fusion biopsy. I'm not going to spend too much time here, but we can target that area very accurately. And oftentimes, if I know that I'm selecting this patient to be a focal therapy candidate, I will biopsy circumferentially around the tumor. In general, when I'm doing a fusion biopsy, I make sure that I try to sample every 3 to 5 millimeters across the lesion to account for any Gleason heterogeneity. So there are many, many, many prostate cancer treatments that exist. It can be overwhelming for patients. And so once patients come to us, it's really important we are the stewards of their care, and we're ultimately what we offer them is what they're going to select from. So I want to now start to talk about what exactly is focal therapy. The concept is to treat the cancer only, of course, and leave the normal prostate behind. And then here you can see, we can clearly see it on imaging, and then you can see a heat map here. And then application of treatment of that index lesion plus the application of a margin. And that margin has varied over time. So initially, the field would apply a 5 millimeter margin, then a 9 millimeter margin, then 11 millimeter. Now it's scaled back to about 9 to 10 millimeters. In general, when I treat patients, I apply a 1 centimeter margin. Also, how we think about treatment is a little bit different. We're focusing not just, of course, the goal is cure, but we accept that when we're doing a subtotal or organ-sparing treatment, that we're really trying to achieve cancer control, that we're trying to delay or avoid whole gland treatment. That is a success for active surveillance, and I believe that would be a success for focal ablation as well. Of course, the less side effects in terms of urinary leakage is the definition is pad-free incontinence or pad-free continence, and that's almost 100% in most series. ED rates are significantly less than both radiation and surgery. There's really no bowel symptoms at all for the most part in the minority of patients who develop a fistula, which are generally in salvage patients. Even that is very rare, about 0.4% in contemporary series. These men can be retreated, so you can apply a second ablation. And I think that's how I counsel my patients up front, that in some men, you only need a single treatment, in some men, you need a secondary treatment. And there are a number of series that, from the UK at least, that have shown that these men can be very successfully salvaged for a long duration with a repeat ablation. And then they can still receive definitive treatment. You don't eliminate the opportunity to pursue surgery or radiation should they need it. I do counsel men that it can be certainly more difficult from an operative standpoint, and the side effects are going to be higher. And that's true of any salvage therapy. So any secondary treatment after a primary treatment, that's going to hold true. Anecdotally, I've done maybe about 3 to 5 post-ablation treatments. These are primarily post-laser ablation, and I haven't been able to notice a huge amount of difference. Certainly, you do see some scar tissue close to where you're operating, but from those surgeons who have done a lot, there's a surgeon in the UK who primarily does these salvage procedures. They kind of rank it as cryotherapy being the most challenging because they have the most desmoplastic reaction, HIFU the next because you can actually find the right plane in the untreated side and follow it across, and then radiation is the least challenging of all of them. So just to put that in perspective. So what are the disadvantages? The long-term outcomes are unknown. Even though focal ablation has been around a long period of time, I think the technology has changed. Outcomes are now starting to be published as people are starting to pay attention. I put this in italics, but the short-term cancer control is theoretically less than surgery or radiation, but I'm not sure that that's necessarily true. We presume that that's the case, but there have been some studies, like a propensity score match study, that showed really there was no difference, even amongst intermediate and high-risk patients. And then, of course, there's the challenges of cost and reimbursement, but that field is changing. So specifically for cryotherapy, there's been a CPT code that has been consistently reimbursed, and it was grandfathered in the 1970s. And then HIFU recently received a Category 1 CPT code in January of 2021, which has largely removed the reimbursement barriers for the most part for patients. So what are the principles of treatment? So you have to pick your poison. So what is the treatment energy modality that you're using? But I don't think that that's a really critical time point. It's really what works for you. At the end of the day, if you heat tissue to 80 degrees Celsius, if you freeze it to -40, if you microwave it, if you deliver electricity an electrical current across it, all of those kill tissue, and all of no carbon-based life form can survive more than 80 degrees Celsius. So if whatever treatment modality that you're using, I think is important, but it's not critical. Image guidance, of course, is an essential principle. The template of ablation that you apply. So here you can see the different types. There's a true focal, which is the index lesion plus the margin. Quadrant ablation, which ends up being the vast majority of cases, because if you think about the size of most prostates, if you're applying a 1 centimeter margin, you're almost always ablating about 1/4 to 1/3 of the prostate. Hemiablation, and of course, dogleg ablations if based on where the cancer is. And then the application of the margins, which I've already discussed. Now, how do we follow these patients post-treatment? So the key components are essentially how I follow men on active surveillance already, but it's imaging, it's PSA, biopsy, and a functional assessment, and this is how I do it. Imaging is at 6 months, and then I do it annually for about 3 years. At 6 months, they do get a biopsy, and that's a target-only biopsy unless it's for cause. So if the PSA did not adequately respond, I expect a greater than 50% decline in the PSA, or I see a rising PSA, or I see a new lesion or persistent enhancement within the treated area, then I would add in a 12 call. But if those men have had a 12 call within the last 6 to 8 months, I don't feel compelled to do that. I'm just verifying that my treatment was effective. And then PSA every 3 months for a year, and then I essentially use an active surveillance protocol. It becomes more and more difficult to convince patients to do a protocol biopsy, and I've started to realize that as I've had like a maturing group of patients. When you have a consistently low PSA, you have imaging that does not show any evidence of recurrence or new lesions, and you already have a biopsy that shows that there was no residual disease. It's very difficult to say, hey, you need to have another biopsy because it's been 3 years since your last biopsy. That's just not a compelling argument. So I'm listing here a few of the different focal therapy energies that exist. There are many. What you see in red is what we currently offer at the University of Michigan. In addition to that, there is microwave ablation, bipolar radiofrequency ablation, water vapor, histotripsy. This space is completely ripe for innovation, device development, new disruptive technologies, a really exciting space to be in. And that's part of the reason that I really chose this space, is because of the novelty and innovation in this space. So this is a common question that I get. How do you choose which technology to use? And there's no one size fits all. I'll start by saying that as you become more and more proficient with different technologies, I think that you can expand your indications. So generally, the transperineal procedures, I think, are better anteriorly because it's very safe up there, even though it's not going to be as precise in terms of forming an ice ball versus HIFU, where you can create any shape that you want. I think you can get right to the heart of the area. HIFU, for me, at least in larger glands, I don't feel that you get the consistent energy deposition. So if you think about it being a transrectal HIFU, that energy has to go through the rectum, then it has to go to prerectal fat, then on VAs, then the peripheral zone, then posterior transition zone, then it has to get to the anterior transition zone. All of that space attenuates the energy. And you don't get good deposition of energy there. And so I personally, I don't use it, but for anterior tumors because I have other modalities available. However, I think in smaller glands where you have adequate reach to be able to reach that area with your beam, I think that's appropriate. HIFU, I most certainly treat men with posterior tumors. I think that you have the highest degree of precision with HIFU because each little area or focal zone that you're ablating is approximately, it's a little bit bigger than a grain of rice, but that's the example that I use. And you stack those little areas up and then you can paint it across the exact contour of the prostate. And you can't really do that with cryotherapy because you just form an ice ball. You can control the size of the ice ball, but you can't control the shape of that ice ball. And I also do think that even I do treat, posterior tumors with cryo as well. However, I do think that men tend to have less irritative voiding symptoms and generally just do better post HIFU, but they're not every man is a good candidate for HIFU or IRE or PDT. The apex is a challenge for every procedure, whether that be radiation, whether that be surgery, where we can experience apical positive margins. We're trying to maximize our urethral length with radiation when they're trying to dose pain and reduce the dose to the sphincter or the urethra. That's always a challenge. And that's certainly the case as well for focal ablation. We get perilously close sometimes to the membranous urethral sphincter. And what we don't want to do is cause incontinence, especially with a procedure that the goal is to preserve quality of life. The issue, though, is not actually during the actual treatment. The issue is in subsequent follow-up if they require salvage. So if your prostate is remaining in situ, you generally have significant resistance that you're not going to experience stress incontinence. However, if you end up ablating one side of the sphincter and then that patient ultimately requires radiation or a salvage prostatectomy, then those men are going to be much higher risk for developing incontinence. And now the reason that I put radiotherapy there is that the radiation oncologists haven't really accepted or really caught on to, I won't say caught on, they're caught on and there are some that vilify it, some that embrace it, just like anything. But dosimetry is a science. There are textbooks on dosimetry. There are dosimetrists. There are MR physicists, and it's a field of study and a clinical career. And they are able to get millimetric accuracy of where they deliver radiation. And so I really think that there is a huge potential for focal therapy in radiation. But the general theme in the radiation oncology circles is that, well, I can treat the whole gland with very minimal morbidity. I don't think I'm going to really achieve that much of a delta. And maybe that's true. I don't believe that's the case, but maybe that is true. So let's focus a little bit more on the ablative modalities that we have available. So first is HIFU, or high intensity focused ultrasound ablation of the prostate. It was FDA approved in late 2015. And prior to that, before it was able to be performed in the US, it was largely done offshore. And offshore, that means Mexico, Puerto Rico, the Caribbean. And that, I think, was really what we're still trying to recover from, because it was difficult to be able to follow patients adequately. It was a very early phase of the technology. We were learning a lot about, in terms of patient safety mechanisms to be able to protect the rectum and those other things. And then once it became approved in the US, it just took time to diffuse in. And only now are we starting to see some momentum where people see the potential applications and where it's being studied and patients are being followed very closely. It generates heat in cavitation. The exact mechanisms are here. So you do have a thermal effect, so a very rapid temperature rise. You have cavitation from the ultrasound energy development. The development and the collapse of those gas bubbles causes a mechanical disruption of the tissue. And then you'll see coagulation, necrosis, and then recruitment of immune cells, and then fibrosis. And you can see here, oftentimes it's a very sharp demarcation from where it was treated to untreated, as would be expected. How about cryotherapy? So what is the mechanism of action here? There's actually multiple mechanisms of action. So the first is during freezing, you have extracellular ice formation, which essentially results in sequestration of the free extracellular water. That leads to increasing osmolarity in the extracellular space, and then cellular dehydration and cell shrinkage. And then intracellular ice formation causes disruption of the organelle and the plasma membranes and impairs cellular function. And then during the thaw, you have the extracellular ice starts to melt before the intracellular ice. That creates an osmotic fluid shift of water into these kind of damaged cells, causing swelling, and these cells essentially burst or rupture. And then the growth of the intracellular ice crystals can continue doing thawing and really exacerbate that cellular damage. And then we have a delayed effect from endothelial damage. It can cause thrombosis and ischemia, activation of the immune response, etc. So what do we see? I'll talk a little bit about the outcomes of these modalities coming up. So what do we see in terms of complications? And this is kind of looking at multiple series, looking at some systematic reviews, and these aren't hard and fast numbers, but this is generally what you'll be able to see. So retention is real. Initially, I used to have patients void in the recovery room. As long as they're fine, I'd send them home. I generally treat my patients on Thursday and Friday. They would have persistent gland swelling over time. They'd come into the ER and urinary retention. That happened in about 30% of patients. So now I always place a catheter, leave it for 3 days, and just have them take it out at home. And then sloughing with the advent of urethral sparing techniques, where you don't necessarily ablate through the entire urethra with HIFU, or you're using a warming catheter, urethral sloughing is generally, I actually haven't, I think I've seen it maybe once of over 160 cases or so, but really not that common. Epididymal orchitis is actually more common than you think. I have a number of men who will have that. And I do give perifoley catheter antibiotics. I know that there's a little bit of voodoo science around that, but the challenge with that is that if they develop an infection or something afterwards, you image them and it's almost always called as an abscess, and you just don't know what to do in that situation. And so you know they're going to be colonized by 3 days with a catheter. And I don't know what the right answer here is yet. Maybe, you're always painted by, a couple of cases that you've seen personally. And I had a patient like that. He started developing fevers, and we scanned him and they said, this is an abscess. I said, no, I just ablated him. And it was this, this continuous battle to say that I can't TOR this guy. It's not the right thing for him. Regardless. So I want to focus in on the fistula rate. The fistula rate is exceedingly uncommon now. There are a number of safety mechanisms that are built into these technologies. So the balloon that surrounds the probe that's placed in the rectum has cooling fluid that's circulating throughout it that keeps the rectum cool. There are built-in treatment cycles where you pause or you have a delay between. It's not treat, but treat, pause a little bit, let it cool, treat. How it treats the gland, it'll treat it here, then here, then here. So it allows parallel areas to cool. So there are a number of safety mechanisms that are built in, and as a result of that, the contemporary rate of rectal fistula is about 0.4%. And when I counsel men with regards to incontinence, I say you have a less than 2% risk of incontinence in general, and that's pad-free continence. In terms of erectile dysfunction, I say about 60 to 70% of men with good erectile function will return to their baseline function at about 12 weeks, and that is true. I think it's actually reported in some of the series are actually higher than that, but I think 60 to 70% is probably closer to what it is in reality. And that's returning to their baseline function within 12 weeks. That's a tremendous difference. If we look at data for radical prostatectomy, 30% of men who start with perfect erections, have a bilateral nerve sparing procedure, will have erections sufficient for penetration with or without the use of an erectile aid. Unless Dr. Singh is doing it, then it's like 90%. So, okay, so let's go a little bit into what studies have been done. Now, it's hard to put this together. Most of these are single site series. This was a systematic review and they couldn't really do a meta-analysis because there were so many. When you look at all the series, everybody has a varying definition of ED, varying definition of continence, varying definition of what's clinically significant, how they follow patients. None of this was standardized until recently when there was a Delphi consensus statement called the Kyoto Consensus Statement, which was developed in Kyoto, Japan. So as I mentioned before, the definitions are variable. Generally, if you have a biopsy, these biopsies are done for cause, and 8% will have clinically significant prostate cancer with 10% requiring additional treatment. ED was variable anywhere from 0 to 40%, incontinence 0 to 50%, but there were some very small series that were included in there. What I mentioned before is generally what you see with focal ablation, and low risk of fistula, and the majority of these patients had low Clavian complications, if any. So we have a prospective series from the UK. This is 625 cases, decent follow-up of 56 months. The endpoints were failure-free survival. And it's important to pay attention to the definition here, because I think that we don't really know how to use PSA, so we can't really use biochemical recurrence. They don't biopsy these men routinely. So whenever it's for cause, then we have a little bit different definition. And so some people feel that it's moving the goalposts, and I do think it's not comparing apples to apples. But failure-free survival means they did not require radical or systemic therapy, they did not develop metastasis, and they did not have cancer specific, they did not die of their prostate cancer. I want to highlight in this series that there was a large proportion of intermediate and high-risk disease here. About 30% of these patients had high-risk prostate cancer. And when we look at the failure-free survival by the definition that was given previously, and remember this includes freedom from radical therapy, of course, across the board at 1 year, it's excellent. If we focus in on the intermediate and high risk, it's 93 versus 89% at 3 years, 88 versus 84% at 5 years. Now, if we look at biochemical recurrence rates across all patients, at 5 years, it's about 29% post surgery. So. And there are a couple of other things that I think are important. We accept positive surgical margins, and that is about 30% in organ-confined prostate cancer. So T2, no extracapsular extension, that is 30% across the board if we look at all surgeons across the United States on average. For T3 disease, or when there's extracapsular extension, that increases to about 50%. But we don't consider that a failure of radical therapy. We just consider that a consequence of the surgery. You had a positive surgical margin, we'll see what happens. But we don't accept that with focal therapy. So what did this series shows in terms of oncologic outcomes? Eight men did have to undergo a salvage radical prostatectomy. 36 underwent salvage radiation. 10 patients developed metastatic disease. But remember, about almost 70 to 80% of this patient population had intermediate or high-risk disease, with 30% of men having high-risk disease. Approximately 20% of men required a repeat ablation, and this was a HIFU series. And what did we see in terms of complications? They did have some endoscopic intervention for LUTS. Again, this is also pre-urethral sparing. I think urethral sparing has largely taken over as the predominant way in which to manage these patients or treat these patients. And the fistula rate, again, was very, very low. How about functional outcomes? 97 to 98% remained pad-free. And if we use that definition of social continence, which we use for after radical prostatectomy, that was about 100%. So really, really strong outcomes. And this is oftentimes immediately after the catheter comes out. They're not waiting 3, 6 months, 12 months to achieve that continence. So let's look at another series using HIFU. This was 2 centers, median follow-up of 36 months, so short to maybe intermediate term follow-up, you can call it. Again, a large proportion of men actually had Gleason grade group 2 or above. So this is the vast majority is clinically significant prostate cancer. Here, the definition of failure-free survival was for-cause biopsy, and also the absence of Gleason grade group 2 or greater within it. Treatment-free survival was any repeat treatment, and then that also included a repeat ablation. And then treatment-free survival by radical therapy is listed there. So if we look specifically at 96 months projected, 81% of men who had clinically significant disease did not require a radical treatment at 96 months. If we look at that at 60 months or 5 years, it's around 91%. And then any treatment is about 60%, which is actually not far off from, really not far off at all from definitive treatment, surgery or radiation. So surprisingly, there aren't many series on focal cryo, at least that are rigorously followed. There was the code registry that was in place for a while, but there was variable input into that registry. And so when we look at kind of intentionally prospectively followed cohorts, this is probably the best series that's out there. It's still a small series. in terms of focal ablation. 122 patients with 5 centers. Again, really short-term follow-up, if anything. The vast majority of these patients as well were intermediate and high-risk prostate cancer. Failure-free survival was 90.5%. 3 to develop metastatic disease, no leakage, great erectile function. 29 of the 122 patients did have a for-cause biopsy, and 20 of those did have clinically significant prostate cancer. So if you're building in a protocol biopsy, like most of us do in the US, those rates are likely going to be higher than it is for cause, of course. And then leakage, again, was any pad use, and ED was defined as sufficient for penetration, as you see here. Very different than sometimes what we use in other technologies. So now I'm going to zip through this so that we have some time for questions. This was the first clinical trial that I participated in focal ablation for prostate cancer, and there are a number of new things coming down the pike. So AngioDynamics have IRE, which is a irreversible electroporation, which is currently enrolling through its PRESERVE trial. That's the FDA pivotal trial for 510(k) approval for IRE. And then there's also a newer technology that's coming in that's going to be starting the clinical trial probably sometime mid next year, which is called Francis Medical. Originally used to be Nextera. Many of you may be familiar with the Resume technology. They sold only the BPH indications to Boston Scientific for very large sum of money, and they preserved all the other indications, and they've now redeveloped it for prostate cancer. So it will be a transurethral ablation for prostate cancer. Okay, so this was a clinical trial that we've actually completed now in terms of accrual, but we are continuing to follow these men. I want to start first by saying that any of these things, starting a focal therapy program is part of like a very major team. There's a couple of people here that I want to point out. This is Amir Lavashi. He was one of my residents. He's now he's kind of like one of the focal therapy attendings at USC. He also did an NCI fellowship in Lauren Corona. You'll see actually performing the procedure a little bit later. She's now a pediatric urology fellow at Lurie Children's in Northwestern. And of course, this is our support staff who are phenomenal. So how does this work? So really the proprietary aspect of this is the oroshells or the nanoshells. They infuse into the bloodstream. They passively accumulate in the extravascular space near blood vessels. And then what ends up happening is that they concentrate in those areas, and those blood vessels are generally where tumors are, because tumors form aberrant blood vessels due to their neovascularization. These nanoparticles are otherwise biologically inert. They don't exert any other potential. But once you put a laser light in their field within the near infrared spectrum, they absorb those photons of that energy, convert that into heat, and cause theoretically a conformal ablation, because it should only happen where the nanoparticles are deposited. So what are these nanoparticles? They are a silica core, and then on top of that, they have a gold shell. The thickness of that gold shell, it tunes it to the exact wavelength of light that you're going to use during the laser ablation. And then there's a pegylated layer so that it doesn't get just completely consumed immediately after infusion. It sticks around for a while. So what do we see in terms of what is the size of these nanoshells here? You can see they are tiny. About 1/50th the size of a red blood cell. So how does this treatment work? So we infuse, the day before, we infuse them with these weight-based dosing of these gold nanoparticles. In these aberrant blood vessels, they disperse into the perivascular space. And then what happens is that we apply a laser light, and as we illuminate it, these nanoparticles absorb that wavelength of light and basically generate heat and cause a lethal ablation. So just to give you an example of why do these nanoparticles end up diffusing, here you can see the difference between normal and tumor endothelium. This is an example from a mammary vessel. This is how we infuse them. They're generally in our infusion center. There is an interesting phenomenon where it actually spoofs the O2 sats. So the O2 sats actually artificially go down, but they're actually perfusing well, and they're not actually hypoxic. And then this is the setup and supply, a little bit crude during the trial. I think if they develop into commercialization, it will certainly be refined. We have a laser diffuser, and here you can see that we introduce these trocars in through the prostate under fusion guidance, and then we place the laser fiber through those trocars, essentially long angiocaths, and then we apply the energy. So what do these what does a patient look like? So this is the first patient I ever treated. It's actually pretty disconcerting because you don't actually see treatment effect in real time. So you just have to hope that you had the treatment. Thankfully, with this trial, patients were imaged at 3 days post-op. So you don't have to wait too long, but that 3 days is a bit nerve-wracking. Here you can see the tumor here on DWI and DCE. He had target-only positive Gleason 3+4. So this is the treatment planning. When we first started, we were applying only a 5mm margin. This is done on the Dynacad software. And this was actually interesting. So the first day that we were doing the treatment, we were doing it in one of our ambulatory surgery centers. And the first time you don't really know exactly what you need. And we realized that we were actually missing the grids. And so I started calling, I called Healthtronics, I called Fortec, I called different companies, and nobody had a grid. My dad's a urologist in the state. I called him, I'm like, you do cryo. I'm like, do you have any grids? He's like, we don't have any grids. So I actually called the company and they said they would overnight them. And it's a little bit time sensitive because they've been infused in nanoparticles. I can't just say, you know what, we'll do this tomorrow. It doesn't work that way. Like, you have to treat them. So I was standing outside of our surgery center, waiting. You know, case starts at 7:30. It was like 8:30, 9 o'clock. I'm like, come on, we got to get going. Where is this guy? This ended up being actually the Amazon van. So that wasn't actually the right thing. But the UPS lady showed up. I took a snapshot with her and said, thank you, you're a lifesaver. Yeah, and then we moved on for the treatment. So this is actually what the treatment looks like in real time. This is actually Lauren Corona placing the needles. We place it under fusion guidance transperineally. We pre-place all the needles circumferentially around the volume to be able to pin it in, because if you start treating one at a time, you have expansion with edema, and then it basically alters what you're actually treating. So what does it look like? If you look like on T2, you don't really see too much changes. The real key is looking at it on DCE. And if you look on DCE there, we have a pretty clear quadrant ablation. And similarly, another cut a little bit elsewhere in the prostate. You can see that a pretty great no enhancement within that area. So on the right is your DCE. T2, you just see the kind of trauma of the catheter placement. In this trial, we actually do a control ablation. So theoretically, on the other side where there's no lesions, we place a laser and we ablate. We should not see ablation because there shouldn't be nanoparticles. And we do see the tract there at imaging, but we actually don't see that ablative effect that you saw on the contralateral side. Really interesting proof of concept. Some of the initial data that was presented just on the first 16 patients that were done. Now we've done over 100 patients. In-field failure-free survival, everybody is biopsied at 3 months, at least within this cohort. Then we moved to 6 months. 12-month overall failure-free survival is 75%. And that's looking at any cancer. Functional outcomes, exactly. You can see here the shim is pretty amazingly stable over the period of time, as well as IPSS and quality of life as well. Oftentimes with focal ablations, you actually see improvements in your IPSS as you reduce the prostate volume. This is what the treatment looks like afterwards. You do have some puncture sites, and they're a little bit sore for a few days, and then they do well. So I want to end this with history does repeat itself. So in Hugh Hampton Young, I don't know if everybody here knows who Hugh Hampton Young is, but he became the chief of urology at the Johns Hopkins in 1897 at the age of 27. And he actually wrote this in 1937, 3 years prior to his death. And he said, we have shown that in early cases, a hemiprostatectomy may be sufficiently radical. The carcinomatous nodule lies, along with its capsule and the seminal vesicle and vas deferens, removing that may be entirely sufficient. So this concept is not new, and I truly am inspired by those who've challenged the status quo and who introduced disruptive technologies into the urology space, like many people here sitting in this room. And so the concept of focal therapy is not new. And I'm hoping to be Marty McFly with, maybe a focal one being my DeLorean. But I do think that there's a tremendous amount of potential in this space, and it has been explored many, many years ago. And maybe this is a renaissance of how we start to think about how we treat patients. So I'd like to thank you for the kind invitation and for allowing me to speak. And then finally, I'd like to give a plug to a meeting that we hold that's both for physicians and for residents as well. We do have a resident abstract session with some small modest cash prizes, but it's basically a crash course in focal therapy with a hands-on component as well. So thank you so much.
role of future role of PSMA in either procedure imaging or post-procedure imaging?
Yeah, so NCCN guidelines now have basically stated explicitly that you don't require conventional imaging prior to getting PSMA PET. So that basically blows it wide open for unfavorable intermediate risk and higher. The challenge that has brought in is, I think it's still early days from a focal therapy space, but eventually where I think it will go will be that we will be able to screen out any of these people who have micrometastatic disease who fail early with surgery or with radiation rather than due to a local recurrence, right? And that is a benefit for everybody potentially. Now, the challenge, though, is that where all the clinical trials in advanced prostate cancer have been done in the context of bulky metastatic disease. So a positive CT scan or a positive bone scan. I actually recently had a patient who is a physician. He had a couple of cores of Gleason 8, underwent a PSMA PET, and he had multinodular or multifocal uptake in the left iliac crest. And it was just one bone. When you look on the CT, the correlative CT, and also his MR, there's no CT or MR correlate there. And so what do we do with this man? And he was 56 years old. Do we confine him to a lifelong androgen deprivation therapy? Is that what we do? I mean, he would have otherwise been considered clinically localized. He would have undergone radical prostatectomy. Maybe he would have failed early, maybe not. Maybe he would fail 10 years from now, and then we would give him ADT. So we don't know what this stage migration or earlier diagnosis of micrometastatic disease with PSMA PET will do. But in terms of primary cancer detection, not every prostate cancer expresses PSMA PET. So until it gets cheaper and more accessible, I think that it won't be used in the focal therapy space unless we move into high risk. But it has the potential to be able to help eliminate bad players so we can improve the success of all therapies that we offer. Yes.
Just kind of on the same post-procedural imaging topic, I know that at least locally, following cryo studies, I think some radiologists don't necessarily grade or aren't comfortable contributing a Pyrex grade
Yes.
to prostates. Is that similar with post-HIFU?
Yeah, so there is, so whenever we have a new space, we come up with a new scoring system. So like there's a new scoring system for clinically localized disease. You score it according to some Likert scale that's been developed by ACR. They have one actually that's post-ablation that's been predominantly used in the UK. We don't really use it that much, but it's actually a little bit easier because you're predominantly relying on enhancement. So you don't really have to look at the diffusion weighted imaging as closely. You don't have to look at T2 because you'll always tend to find some, hypointense area there. But because you're relying on DCE, it's actually easier to interpret a post-ablation MRI than a de novo MRI. Yeah. Sorry, Dr. Singh.
One is your entire talk, I did not see age or life expectancy mentioned once in any of the slides. And focal therapy is maybe a little anecdotal, but I've been using cryo since probably late 90s, been exposed to it. 2002 was the first time I did cryoablation. Over the years, we have used focal on probably, I would say, 10, 20 patients over 15 years, not a big part of my practice. Early years, it was a bigger part of practice, till surveillance kicked in. So now, when you go back to initially when we said the index patient or the ideal patient, I can tell you that group makes less than 5% of people I get to see in my office, because either they're young in their 60s with 20, 30 years of life expectancy, where when I see data that say that 96 months, it's not insignificant failure or shift to radical arm, or they're 70 and older, where surveillance data used to be, when surveillance first kicked in, way back many years, it was like 75, you kind of look at them, Gleason 6 or Great Group 1. Now the surveillance arm has shifted down to 60s for low risk disease, and definitely for 70. And even in that group, you don't have much of a morbidity. So is almost what's taking a disease process and changed into a bi-modality treatment arm. So where they're too young, too lethal, too high volume, or they're not enough, so that middle space becomes a lot smaller. That's number one. Number two is in terms of ablative technology. When you go back to your contraindication slide, seeds, calcification, size of the glands, all of those things. And I'm just playing devil's advocate here, and I had this conversation at a way with Hydroguy. I said to him, I said, if cryo, we know we have almost 30 years of data that cryo is not a failure of ablation. Most of the cryo failures, when they're in kidney or prostate, is failure of technique. It's because we didn't freeze the right area, we got too uncomfortable coming down posterior, so on and so forth. So in that space, when all of those contraindications are met, easily with the cryo in your practice, the marginal improvement of something like ablation, when I look at it from a healthcare system and cost investment, how do you justify making that investment in that technology?
Yeah, that's a very good question. I'll address the first thing in terms of age. So you're right, there aren't any specific criteria with regards to age. If we look at NCCN guidelines, they say that if your life expectancy is greater than 5 years and you have Gleason 7 or above, then you should be treated with radiation. So, and if it's greater than 10 years, then you have any option that's available to you. The quandary is that those men who are younger have the most to lose, right? But they also have the most to gain from focal ablation, right? Those are those are the men who generally have good sexual function, they're sexually active, they've got families, they're working, versus the older patient who, yes, it can be less invasive and you can offer them a treatment that's not as radical, but they may not have erections anyway. So what are we really gaining here by offering a focal ablation? That's one thing. I don't think that you're right. Right now, we're stuck into this bimodal distribution. And a lot of these arguments that we had against active surveillance was exactly what is being brought forward to focal therapy now. And I do think that these are mutually exclusive populations. Somebody who's a surveillance candidate, there's a narrow group in which are both surveillance and ablation and radical therapy candidates. But for the large part, and that may be that grade group 2, favorable, intermediate risk maybe, but largely low risk prostate cancer should be managed with surveillance. It doesn't, irrespective of the age, we know that they will do well. They're not going to metastasize on surveillance. We identify those men and transition to definitive treatment. When we say like it's a failure in technique, when you have a 30% positive surgical margin rate, when you have a 30% biochemical recurrence rate with surgery, it's easy for us to say this is the biology of the disease. But when we do an ablation, it's also easy for us to say, well, you know what? Focal therapy is not the right thing for prostate cancer. Similarly, when we do active surveillance, when you get 5 years on surveillance and they transition to radical therapy, we say, you know what, we got you 5 years on active surveillance. You preserved your erections for 5 years. You were continent for 5 years. You know, this is a win for surveillance. However, like you mentioned, Dr. Singh, we see that as we go out, we start to see failures, and that's true of anything. But when we see that, we criticize the technology, and we didn't say, hey, that person got 96 months without radical therapy, right? We say 81% of men got 96 months without radical therapy. Rather, we say 19% of men have to get radical therapy. This treatment failed. And so I do think that there is a bit of a dichotomy there, but your point is extremely well taken, right? We can't just blindly accept focal therapy and just say, this is what we need to do. And there is a huge amount of work that remains to be seen in terms of the data that needs to be generated for us to do it. There is now that data is starting to come forth. I didn't highlight it, but I have another talk that's just on clinical trials in focal therapy. But there's the POT trial that's being run by Freddie Hamdi. That randomizes men into, well, now it's transitioned, I think, into PDT versus radiation or surgery. There is the Kronos trial, which is run by Hashim Ahmed at Imperial College London. So that's very interesting. They have Kronos A, which randomizes men into radical therapy versus focal ablation. But they have another arm. What they ended up finding was when they did the development study of the POT trial, Freddie Hamdi's trial, they found that once you counsel men, it's very difficult to maintain equipoise. Everybody wants to undergo focal therapy. When you hear the discussion between the two, why, as a layperson, right, you have the knowledge of, everybody here has the knowledge of understanding the biology of prostate cancer and outcomes. But when you hear that, everybody was dropping out of the radical therapy arm. So they built a second arm which basically says if you have a strong preference for focal therapy, you will still be enrolled on trial, but you'll be enrolled on alternate arms. So it'll be focal ablation alone versus focal ablation plus finasteride plus focal ablation plus Lupron. So you still generate data and evidence to be able to study this, but you also take into account the patient's preferences. And then the final thing that I'll say, I'm sorry, this is a very long-winded answer, is that, you know, shared decision-making, to us, it sometimes seems like a foo-foo concept. But if we look at kidney stones, we offer a patient, hey, you have a 1 centimeter stone. We can either offer you a ESWAL and you counsel them to ESWAL, or you can do ureteroscopy. As a urologist, you think, why doesn't everybody choose ureteroscopy, right? They have a higher stone-free rate. You can get in, you can visualize the stone. It's not done on this nebulous, like ultrasound guidance. Many patients choose ESWAL. We accept that as part of the shared decision-making process, that they can accept a trade-off in the risks and benefits of their procedure to be able to choose a treatment that aligns with their goals of care. But it's much harder for us to accept that in prostate cancer. And I agree with that to a certain degree, because again, we have to be able to channel patients into what is right for their care, because they certainly don't have as much knowledge as us. But I think that the example still holds true, that we can't apply it in some areas and completely ignore it in other areas. Yes.
Whole gland.
Yeah, so I don't generally do a lot of whole gland ablations, but I have a number of colleagues who do, and they will achieve undetectable PSAs. I think that, you know, when I have a patient who's really wanting to pursue ablation, I think that you can get pretty close to achieving similar outcomes with radiation, especially if it's erectile functional preservation that they're looking to preserve. And I think that's true for HIFU, but for cryo, I think whole gland ablation, you do have significant ED and those kind of issues. But if you can do like a nerve-sparing HIFU where you can avoid the nerves, I think that logistically it works out for some patients in that they don't have to go for 40 treatments of radiation 40 fractions if you're not getting SBRT or you don't offer SBRT. That it's a potential option. In my practice, I don't use it that much because I feel that if they're going to get a whole gland therapy, the more of the prostate that you treat, it's diminishing returns in terms of the functional outcomes. However, there are logistical and other benefits to it, but it's certainly an option that a lot of people use. I think that the whole gland oncological outcomes actually are very not that far off of existing radical therapies. But when we have like guaranteed insurance coverage and expert surgeons and expert radiation oncologists, it can be difficult for me to do it when there's uncertainty historically regarding coverage. And that's changed now, but that's my practice. Yes.
I had two quick questions. One, what's been your experience with salvage prostatectomy post focal therapy? And also, I was just hoping you could talk a bit about transurethral HIFU.
Yeah.
What it is, what are the indications, kind of counterpoint to traditional.
Yeah, absolutely. Yeah. So in terms of your first question, in terms of what do we see after radical prostatectomy for salvage? So there have been a couple of series that have been published. One is Vip Patel series, but he combined that with radiation patients in addition to focal patients. Generally, the ED outcomes are not great, but the continence outcomes are actually pretty good. You can achieve it in 80+% of patients. So that's good. And that's similar data that came out of the UK. A surgeon called Paul Cathcart there, they kind of centralized their surgeon care versus their kind of clinic care. And so he has done a tremendous number of these. And when I was telling you the transition between HIFU versus cryo versus radiation, that's really his statement. For the cases that I've done have been either post-nanoparticle laser ablation, or we ran a trial at the NIH with in-bore focal laser ablation. Oftentimes I would not see, at least when I was doing the lateral aspects in the posterior gland, I wasn't seeing a lot of treatment effect. And that was because we tended to favor anterior tumors because it's just a safer margin. There were two cases where I thought I was digging into cancer. Digging into cancer was right at the apex. I was like at the muscle and it was all looked devitalized. I sent a bunch of frozens and it was all negative. It was just the ablated tissue that I thought was cancer, but it was just this destroyed tissue that was like devitalized. And then in terms of TULSA, I think that that team, the TULSA team, the engineering team, they are brilliant. They're all engineers, and if you talk to them, you wouldn't even know that they're engineers. You'd think that they're a urologist. They've really studied this aspect well. The challenges for TULSA is a couple of things. One is that TULSA happens in bore. So urologists don't have control of the MR suite. And while they claim that these procedures, once proficient, can be down to 1.5 hours, in reality, along the training curve is about 3 to 4 hours. And I don't know if you can get it that much faster than that, maybe 2.5 hours. I would be suspect unless you're super high volume and you have a streamlined system. Then you can get it done faster. And the problem with that is that we already have problems getting prostate MRIs done. The hospital would much rather do 8 neuro MRIs in the same period of time and make 10 times the money rather than doing one TULSA, for example, right? So that's a challenge. The other thing is that revenue needs to be split between, the radiologist that you're working with and that. So that also kind of brings it down. And then again, like I mentioned, we don't have control of the MR suite. But the final thing is for TULSA that's challenging is that the CPT code was specified transrectal HIFU. So that category CPT code does not apply to transurethral HIFU. So there will be continued challenges with reimbursement there until there's an analogous code that comes through. But it does have some unique advantages in that there's really generally not a challenge to be able to treat the anterior gland. Because you're transurethral, there's so much less tissue that you're going through, so you can treat that very adequately. You can't treat periurethral tumors very, very well because the beam can't reach right next to itself. So you have sparing of about 3 to 5 millimeters of tissue there. But that's not necessarily different from cryo where you use a warming catheter. But with that, you can stop the warming catheter and freeze into the urethra on one side. You don't have that option with TULSA. And otherwise, I think it's the same concept of however far away, so posterolaterally, I've been told, I haven't done any myself, but from a very experienced person that because that distance is so long and you build the heat along the tract, at the farthest point, you may not get the energy deposition that you're hoping for. It relies on MR thermometry, which is an advantage because during transrectal HIFU, you don't oftentimes get real-time feedback. In some systems, they may tell you, oh, yes, it changed from this to this. And so maybe that means treatment or not, but you don't have a great idea. Whereas with MR thermometry, as finicky as it is, their algorithm is pretty good. And so you can actually see the areas that have been treated and you can ensure that you've achieved lethal temperatures within those areas. So there are advantages and disadvantages to TULSA. It'll certainly play a role, but I don't think it's going to take over the market for the reasons that I mentioned. All right. Well, thank you so much. Really appreciate it. Thank you. I'm going to leave my